we rarely talk about what it actually costs a body to build a person. The narrative is usually just a glowing progression toward birth, but when you strip that away, pregnancy is an intense physiological stress test. And for people with adrenal insufficiency, that stress test is happening without the body's natural shock absorbers.
It is, and the shock absorber metaphor is exactly how it feels. With adrenal insufficiency, your body cannot produce cortisol. Cortisol gets a bad reputation in wellness circles as just the stress hormone that makes you tired or wired. But fundamentally, cortisol is what keeps your blood pressure stable, your blood sugar regulated, and your cardiovascular system functioning when you are under physical demand. So when someone with adrenal insufficiency gets pregnant, they are entering a 9-month period of escalating physical demand without the internal mechanism that usually rises to meet it.
Because a healthy body normally ramps up cortisol production automatically. It just handles the load behind the scenes.
It handles it beautifully. In a typical pregnancy, circulating cortisol concentrations increase 2 to 3-fold, climbing continuously from the first trimester onward. The placenta actually produces corticotropin-releasing hormone, which influences the whole stress response system. Cortisol-binding proteins change. The maternal system knows it is supporting 2 lives and just scales up production. But if your adrenal glands are essentially offline, either from Addison's disease or secondary adrenal insufficiency, none of that automatic scaling happens. You are relying entirely on external steroid replacement to manually mimic what a biological organ should be doing dynamically.
That manual mimicry sounds exhausting. You're effectively acting as your own endocrine system.
You are, and it brings a very specific kind of uncertainty into the experience. Pregnancy already carries this quiet sense of the unknown for anyone. Your body changes, your energy shifts, but when you add adrenal insufficiency into the mix, that uncertainty feels much heavier. You are not just thinking about the baby's development, you are constantly monitoring how stable you feel, calculating whether a sudden drop in energy is just normal pregnancy fatigue or the beginning of a dangerous cortisol deficit. And there is a lot of pressure, this underlying expectation that you should be able to manage this seamlessly, even though your baseline physiology requires a level of micromanagement that most people can't even fathom. The stakes are life and death, frankly. Adrenal crisis during pregnancy is uncommon, but it is associated with significant maternal and fetal morbidity and mortality if it goes untreated or undiagnosed. If a pregnant woman with adrenal insufficiency experiences a severe illness, intractable vomiting like hyperemesis gravidarum, or even severe emotional stress, she can burn through her available cortisol. Without intervention, that leads to a crisis characterized by severe weakness, plummeting blood pressure, hypoglycemia, and eventually shock. The margins for error are just incredibly thin, which means the mental load of staying safe is immense.
Let's look at the 3rd trimester. The metabolic demand is peaking. What happens to the replacement dosage?
The dosage has to shift, usually around the 20th to 24th week. Medical guidelines recommend increasing the hydrocortisone maintenance dose by 20 to 40% to mirror the physiological cortisol levels of a normal pregnancy. But it is not a perfect science. Finding the right balance requires constant communication with an endocrinologist. If you under-replace, you risk an adrenal crisis. If you over-replace excessively, you can run into other complications. And you are trying to parse out whether your symptoms are from the medication, the underlying disease, or just the fact that you are growing a human being.
The overlap in symptoms must be maddening. Nausea, fatigue, dizziness, those are standard pregnancy complaints, but also the early warning signs of adrenal failure.
Maddening is the right word. It creates a hypervigilance that is hard to turn off. If a pregnant woman without a chronic illness feels exhausted and slightly dizzy, she might just think she needs to sit down and eat a snack. If I feel exhausted and dizzy, I have to immediately ask myself if my blood pressure is dropping dangerously low because I do not have enough cortisol. The diagnosis of adrenal insufficiency during pregnancy is sometimes missed entirely in new cases because the symptoms are just dismissed as typical pregnancy complaints. For those already diagnosed, it means you can never fully relax into the experience.
We're treating the condition as a fragile state. But wait, is the pregnancy itself inherently going wrong, or is it just that the management requires a completely different operational framework? Because framing it as inherently dangerous might do a disservice to the patients.
I see the distinction you are making, but I struggle to separate the two. You are saying the pregnancy is normal, it is just the management that is complex. But when the management is the only thing keeping the mother and child alive, the pregnancy is inherently high risk. Women with adrenal insufficiency are categorized as high risk in medical settings, and that framing exists for a reason. It secures the closer monitoring and the multidisciplinary care team required. Studies show they face an increased risk of adverse events, including preterm delivery and postpartum hemorrhaging. So while the biological process of growing the baby might be proceeding normally, the environment it is happening in is inherently precarious.
I'm not sure that holds. Labeling the environment as precarious suggests fragility, whereas successfully carrying a child while manually managing an endocrine disorder demonstrates a profound physiological resilience. The danger is real, but the framing matters.
Actually, the better way to put it is that the vulnerability and the resilience coexist. You are right that framing it only as dangerous strips the mother of her agency and minimizes the incredible work her body's doing. The body is resilient, but it is a supported resilience. When things go well, and most deliveries do occur without complications, when the pregnancy is carefully followed and treatment is optimized, it is because of that rigorous operational framework you mentioned. But the fear of the fragility is a very real part of the patient's psychological landscape. They are constantly walking a tightrope, and pretending the tightrope is a wide bridge does not make the drop any less steep.
Let's talk about the drop. Labor is the ultimate physiological stress event. How does a body without an automatic stress response navigate childbirth?
Labor requires an immense mobilization of energy and cardiovascular stability. In a normal body, cortisol spikes dramatically to sustain that physical effort. For an Addison's patient or anyone with adrenal insufficiency, going into active labor without a massive influx of external steroids would be catastrophic. The standard protocol requires aggressive stress dosing. At the onset of active labor, the patient needs an immediate 100 milligram intravenous bolus of hydrocortisone. That is followed by a continuous IV infusion of 200 milligrams over 24 hours or 50 milligram injections every 6 hours until after delivery. It is a highly choreographed medical intervention designed to artificially replicate the body's natural defense mechanism against the trauma of birth.
That protocol has to be locked in long before the first contraction. The hospital needs a written therapeutic plan.
Exactly. The endocrinologist must provide the obstetric team with a specific written plan for intravenous glucocorticoid coverage well before the due date. And the patient has to carry that plan, advocate for it, and ensure the medical staff actually follows it. You cannot arrive at triage in active labor and hope the attending physician happens to be deeply familiar with primary adrenal insufficiency. You have to be the expert in the room. And that brings a level of physical demand that is difficult to anticipate. Even when things go perfectly to plan, the body is working so hard behind the scenes that the energy depletion is profound.
Then comes the postpartum shift. The baby is out, the placenta is gone, and the hormone crash begins.
The postpartum period is arguably the most volatile phase. You have a sharp, sudden drop in estrogen and progesterone. The placenta, which was contributing to the hormonal landscape and producing corticotropin-releasing hormone, is delivered and removed from the equation. The body has to adjust all over again, returning to its pre-pregnancy state, but without internal cortisol regulation to smooth the transition. Patients usually require sick-day doses of hydrocortisone for about 48 hours after delivery, before slowly tapering back down to their usual replacement regimen. You are navigating physical recovery from a major medical event, severe sleep disruption, and massive hormonal shifts simultaneously.
The vulnerability there is absolute. Distinguishing between normal postpartum exhaustion and a dangerous cortisol deficit seems nearly impossible.
It is terrifyingly ambiguous. Many describe hitting a wall after the intensity of delivery fades. There is a brief, stable window, usually while those high IV stress doses are still in their system, followed by a noticeable crushing dip. You feel more depleted than expected, and you have to decipher if that is because you were awake for 30 hours giving birth or if your hydrocortisone dose is tapering too quickly. And this physical vulnerability bleeds directly into emotional vulnerability. Postpartum mood changes are already influenced by sleep disruption and physiological stress, but adding an inability to produce cortisol internally adds a dense, complicated layer. The emotional sensitivity increases right alongside the physical fatigue.
I keep getting stuck on the idea that the medical community might view this entirely through a clinical lens, adjusting doses, monitoring potassium, while the patient is experiencing a profound psychological undertaking.
That disconnect is one of the most isolating parts of the experience. The clinical approach is vital. Without the precise adjustment of hydrocortisone and fludrocortisone, the patient does not survive. But the medical framing often stops there. A doctor looks at a stable blood pressure reading and a normal metabolic panel and declares the pregnancy a success. Meanwhile, the patient is navigating a deep, quiet grief over the loss of a normal pregnancy experience. They are carrying the burden of intense vigilance. Every flutter, every wave of nausea, every dizzy spell requires a cognitive calculation. The emotional demands of needing to be constantly vigilant, dealing with information overload, and balancing the fantasy of a normal pregnancy against the reality of a chronic disease are rarely addressed in a standard obstetric appointment.
I don't know, that feels too clean to me. Claiming the medical community ignores the psychological aspect, ignores the growing field of maternal-fetal medicine, which specifically integrates psychological support for high-risk pregnancies.
It is getting better, certainly. Maternal-fetal medicine specialists are far more attuned to the psychological impact of high-risk pregnancies than a general practitioner might have been 20 years ago. But access to that kind of integrated care is a privilege. In many settings, especially outside of major tertiary care centers, the focus remains intensely, sometimes exclusively, on the biological metrics. And even with the best supportive care, the patient still has to go home and live in that body. They have to wake up at 2 a.m. feeling strange and make the solitary decision of whether to take an extra pill, go to the emergency room, or try to go back to sleep. The medical team provides the map, but the patient is the one walking through the dark.
Which forces a radical kind of self-advocacy. You are the ultimate authority on your own deterioration.
You have to be. There is no other option. You learn to read the microscopic shifts in your own energy. You start noticing patterns, how your body responds to a minor stressor, how long a stable period lasts before a sudden drop in energy. Many find it helpful to just begin with awareness, rather than trying to perfectly control everything, keeping simple notes on stable versus depleted days, gently thinking ahead to transition points. It is about building a highly specialized fluency in your own physiology.
And part of that advocacy is demanding that your care team listens when you translate those physical sensations into medical concern. Despite all of this, the risk of crisis, the medicalization of birth, the relentless vigilance, people with adrenal insufficiency still choose to start families. The drive is stronger than the danger.
The drive is fundamental. For many women with chronic illness, their disease is experienced as a deviation from normality, and the ability to conceive, carry, and birth a child brings them closer to a sense of normal human experience. It is a balancing act between the burdens of the illness and the profound blessings of creating a family. Yes, the pregnancy is fraught with anxiety, and the specter of complications is always hovering, but the joy of holding that child, of expanding your life beyond the boundaries of your diagnosis, is a deeply powerful motivator. It is worth the risk because life is worth the risk. The illness dictates the terms of the pregnancy, but it does not get to dictate the boundaries of the patient's future or their capacity for love and family.
It requires rebuilding trust in a body that fundamentally betrayed you when the adrenal glands failed.
That is the emotional core of it. When you are diagnosed with adrenal insufficiency, your relationship with your body fractures. You learn that your body cannot sustain itself under stress without chemical intervention. Deciding to carry a pregnancy is an act of radical, cautious hope. It is asking a compromised system to perform a miraculous task. And as the pregnancy progresses, as the weeks turn into months and the baby grows, there is a gradual, tentative rebuilding of trust. You begin to see that even though your body needs external support, it is still capable of immense strength. It is holding both realities at once, the fragility of the condition and the undeniable power of the biological process.
You make space for the vulnerability without letting it consume the entire experience.
Exactly. You let go of the expectations about how things should feel, and you allow the mixed experiences to exist without judgment. It is okay that it feels hard at times. It is reasonable to need more rest, more space, and more time to feel steady again postpartum. Reducing the self-blame, the guilt that you might not be giving your child a perfectly stress-free environment is a crucial shift. Over time, you find a rhythm, not a perfect rhythm, but one that feels familiar and manageable. You realize you are allowed to move through the experience at your own pace, honoring the specific parameters your body requires.
It is a deliberate integration of a medical reality into a deeply human milestone. The effort itself is a testament to the value placed on the outcome.
It is an incredible testament. The careful management, the stress dosing protocols, the hypervigilance, they are all acts of devotion. Navigating adrenal insufficiency alongside pregnancy and postpartum recovery is an intricate, exhausting dance. But for those who choose it, it is a dance of profound consequence. You are working with the body you have to create the life you want, and there is an inherent beauty in that resilience.
We've covered a lot of ground today, exploring the quiet realities of managing adrenal insufficiency through pregnancy and postpartum. If you found this perspective helpful, please share it with someone who might need to hear it. It matters that these conversations happen.